rudimentary foundational understanding, okay? I'm not going to be asking you guys to calculate values based off Henry's law or Dalton's law or any of those things. We will need to do some calculation of lung volumes, but we're going to have a very foundational understanding, not too deep into the biochemistry or the physics or anything like that. So what you're going to find is that probably the next 35, 40 slides are extraordinarily redundant. And it's purposeful. It is purposeful so that the point is being made. But I'm going to try to make it as easy as I can. I've added a couple of slides for your benefit. And they're pictures, not any actual new material. So I'm going to send them out for you because sometimes people just like to have these pictures. But you're also going to see a lot of values about this many millimeters of mercury and this many millimeters of mercury moving in, moving out. We're not going to worry about those specific values. What I want is a global comprehensive understanding of the foundational principles of how does air move into the lungs and how does it get out. And it's very simple, okay? So what I plan to do is go just a little bit extra today. Not extra past my normal time, but extra past what I usually do, okay? And then tomorrow we'll start, probably finish off about 30-ish slides before the lab. Probably just means we'll have to shorten the lab time per group a little bit, and then we'll move into the lab space. And of course, the lab will be open. I have it after we're normally scheduled, so if anybody really wants to get a fuller experience, we have plenty of time. So I don't want to shortchange you in any way. Is that fair to everybody? So I am sorry about yesterday, okay? So here we go. And I also know you have biochemistry tomorrow, so I've got that in my mind. Don't worry about that, okay? So today we're going to talk about, we're into the physiology now. We've talked about the anatomy. The anatomy is pretty straightforward, right? We hammered home over and over again the functional versus structural unit of the lobule versus the acini, right? And what's the difference? It's that little bit of terminal bronchiole that doesn't have a functional use, right? It's just a conducting pathway. Remember that? Okay. So how does that happen now? How is the air moving in? How is it moving out? Does anybody remember this? Did anybody see this in like 8th or 9th grade science or biology? Okay? If you understand this little thing, you will understand the next 35 slides because this is all that it is. What happened, the green balloon at the bottom represents the diaphragm. Obviously the red balloons represent the lungs, and that is the thoracic cavity, right? What happens when the diaphragm expands? Where does it go? It moves down. So what does that happen? What does that mean for this space or the space inside that glass container? It gets bigger. And as it gets bigger, what happens to the pressure inside of it? The pressure goes down, and what happens? The balloons blow up. That's it. Okay? I mean, that is it. It's not easy. It's not that easy. It can't be. But that is it. And I'm serious. If you understand that concept, you got it. Okay? What happens then? And again, think about it. Inhalation, is it an active muscular process? Yes. Why? Because muscles have to contract and move actively in order to move down, expand the rib cage, and then allow that pressure to drop, right? What about when you just let go of the balloon at the bottom there? It's a passive process. Exhalation should be just a relaxation of the muscles, shortening and narrowing of the thoracic cavity, and the balloons let their air out. Does that make sense? Okay? And really, that's what we're going to go over again and again and again and again. Conceptually, you guys got it already, though? All right. And I'm serious. I wouldn't put this on here if I wasn't being serious. We'll layer on, of course, but that's the main part of it. Key piece of information moving forward, difference between ventilation and respiration. I know you guys can read, but somebody give me, what is the difference between ventilation and respiration? Go ahead.
So ventilation is like a mechanical process and respiration is like a chemical.
Sure, that's a good way to put it. Another way to put it would be that ventilation is the movement of air, and respiration is the exchange of oxygen and carbon dioxide. So you're absolutely correct. Think about it simply, ventilation is just moving the air, right? What does a ventilator do? It's a machine, right? That would be a way to keep it straight in your brain. It's a machine that just moves the air. It doesn't respirate, it moves air for you, okay? So anyway, pulmonary ventilation, aka breathing. Simple, right? Movement of air in and out. Where is my scoop? There. Movement of air in and out. External respiration, that's bringing oxygen from the alveolar air to the blood, right? And bringing carbon dioxide from the blood to the alveolar air for exhalation. And then cellular or internal respiration is a utilization of that oxygen at the tissue level. All right, does that make sense to everybody? So we got to get the oxygen on board the blood in the alveoli, then we've got to offload it at the tissue level and that for their utilization. So that's external versus internal or cellular respiration. Clear enough? Okay. So this is like the point of that little balloon thing. Alternating pressure differences, and that's really what it's going to be. All right? There is a constant negative pressure, just to preface some slides, there's a constant negative pressure in the pleural space. In the pleural space. What's the pleural space? The pleural cavity, what is that? It's the space between the visceral and parietal pleura, right? And what's in there? Pleural fluid. Any surfactant? No. Why? High surface tension. Adherence of the parenchyma to the wall so it doesn't collapse. That negative pressure that's in there also helps maintain that adherence so that the lungs don't collapse in on themselves. In the lung tissue, in the intrapulmonary pressure, at rest, if I'm not doing anything, breathing in, breathing out, external pressure is the same as alveolar pressure, right? Well, it is, I'm telling you, right? If you're not doing anything, there's no pressure differential, so there's no air movement, right? So then we expand the cavity with inhalation. What happens to the pressure in the alveoli? We already said it. Pressure goes down, air just tumbles in, right? Reduce the size of the cavity, both anterior, posteriorly, and vertically. And what happens? Air comes out, okay? And that is it, simply. We have other, we have accessory muscles. We have other factors, and we're going to talk about the other factors, but really it is a simple pressure differential that's created by the movement of the diaphragm and the external intercostals primarily. Those are our primary muscular muscles of respiration. And most of that is the diaphragm, right? Most of that is the diaphragm, increasing the vertical diameter of the thoracic cavity. So, CPAP is a good example here. Another good example is pretty much anything that blows air into the lungs, right? And CPAP, continuous positive pressure. What does that mean? Higher pressure than what's in the lungs, so that if you have an airway obstruction, like your uvula, like the redundancy of your soft palate, like tonsils, anything that falls back and occludes that airway, it pushes air right through it. Right? So we just have airway as opposed to a negative pressure because we're just normal inhalation. We have a positive pressure to force air in there past an obstruction. Ventilator does the same thing, all right, at a much lower pressure. Okay. Here's a more less grade school photograph, right? But this is the same thing as that balloon diagram. It's the same exact thing. As we see on the left side here, or your right side, I guess, I don't know. As we see here, the cavity increases during inhalation, and so air just naturally flows in due to a lower pressure here. As we reduce the size of that cavity, we get a higher pressure, and so air travels outward. I'm going to say that over and over and over again. I want to make sure, principally, you guys have it, because I don't want to insult anybody's intelligence, but really what we're looking for at this level is that. Foundationally, you just understand that, okay? So let's make it more complicated. All right. We've already gone through this. These were already defined earlier, but some new ones. So atmospheric pressure, 760 millimeters of mercury, 1.4 if you're British. Okay, so that is a normal atmosphere. One atmosphere is 760 millimeters of mercury. Okay. At rest, that pressure is equal on the outside, and this is sea level, of course. We're not doing any of that. Sea level. That's the same pressure. If I'm not doing anything with my diaphragm and my lungs, that's the same pressure that's in my alveoli and that's in the atmosphere around me. Okay? So there's no net movement of air. When those pressures change, aka a pressure differential, now air is going to start moving one way or the other, right? Okay. Intrathoracic and intrapleural, those are not exactly the same. The entire thoracic cavity pressure and the intrapleural pressure are not necessarily exactly, but it is minute, maybe millimeters of mercury, not whole atoms. I mean, just very, very minute difference. So we're going to call them equal here. Does that make sense? And we're just, honestly, what I want you guys to think of is the intrapleural pressure. What does that mean? Don't confuse intrapleural with intrapulmonic or intrapulmonary, right? Pleural, cavity, the space between the lungs and the chest, right? Pulmonic, in the lungs, alveolar. Does that make sense, everybody? Get those terms correct. I don't want you to see intrapleural pressure and think I'm talking about the pressure in the lungs. I'm not. I'm talking about the pressure in the cavity. Is that clear? Okay. And again, the reason why we have these definitions is because you'll see pleural or thoracic or, I don't know why I'm losing my little guy today, alveolar or pulmonic, right? So we're talking about the same thing. In the lungs, outside the lungs, okay? So, as I have said, and will say again, the atmospheric pressure, I'm going to go with this because I'm losing it today. Atmospheric pressure, 761 atmosphere, 1 ATM, 1 torr, again if you're British, is what our normal atmospheric pressure is at sea level. That is the same pressure in your alveoli when they're not doing anything. In your alveoli, right? Again, no air is going anywhere. When airflow begins, we've got to get the pressure in the lungs to be lowered. Okay? How do we do that? Muscles. Right? Yeah. There is Robert Boyle. Okay? I will be having identifications of scientists on this slide. That's one of your questions. Will be who is this in this picture? Boyle's law. Why is Boyle's law important? Because Boyle's law is the mechanical, mathematical representation of what I've been talking about, right? As the pressure of a gas, as the size of the container of a gas, an enclosed amount of gas gets bigger, the pressure gets lower, right? Okay, and so if you have a fixed space, as the pressure, as that space gets bigger, if you have a fixed amount of gas in that space, you have more room for the molecules to bounce around in, so a lower pressure. If you decrease the size of that space of a fixed amount of air in a fixed container, then you have higher pressure. That really is the representation. Of course, our lungs aren't fixed spaces, right? They're not. But Boyle's law still does apply. And so as you increase the size of the space, we have a lower pressure, air funnels in. You decrease the size of the space, the pressure goes up, air comes out. That is the application of Boyle's law, clinically. Okay? And that's where we need to get. Am I going to give you values of P and 1 and V? And then, no. But I just need you to understand how Boyle's law applies clinically to your patients and patient care, and just being alive in general. Do you know what I mean? Okay? Does this make sense? Okay. This is the same thing. I told you that one picture was going to equal 35 slides. All right, you guys? It's the same thing. Okay? This also helps, right? This button where the little red guy is, right? That helps. The cohesion. What causes that cohesion of the visceral and the parietal pleura? One, it's the fluid, the pleural fluid, not the alveolar fluid, the pleural fluid that helps that create higher surface tension, right? And somebody came up to me and they had a good example of surface tension with and without. If you take like a Ziploc bag and you put a little bit of water at it and you push it together, it becomes hard to pull apart, right? It wants to collapse in on itself no matter which way you do it. If you put like one little drop of like Dawn soap in there, it'll pop right open, because soap is also a surfactant. So that's what I'm saying, high and low surface tension, right? In the pleural cavity, we want high surface tension. We don't want that collapse, right? We want it to adhere tightly, the visceral pleura and the parietal pleura, right? The other thing that can change that besides the surface tension is the pressure, the negative pressure that's inherent in the pleural cavity that I'll discuss with you in a minute. So we have these two things that are working in concert synergistically to keep the lungs from deflating. Does that make sense to y'all? Okay. And then again, this being an active process, right? An active contraction of the diaphragm, an active contraction of the external intercostals. We do, of course, have accessory muscles that we'll discuss, where you can take a forceful, more deep inhalation, or you can blow extra air out, right? Everybody here has been excited or run or done something where they have to take a deeper breath, right? I hear it a lot before exam. Okay, so yeah, here we go. The diaphragm, normally, when it is relaxed, it is more curved, right? And we have the lungs that are sitting on top of the diaphragmatic surface. We have the liver right there. We have the pancreas, and we have the spleen sitting just below it there. As it contracts, it goes from sort of this concave to sort of this more flattened shape in order to open up and expand the size of the thoracic cavity. So the contracted diaphragm is down here, right? Actively. It increases the vertical diameter. Does that make sense? Right? Diaphragm goes down, lungs go with it because of the surface tension and the negative pressure. Right? This is one reason right here why C-spine injuries are so life-threatening, because the phrenic nerve innervates at C345. So what happens if you have a cervical injury at that level? You lose innervation of the phrenic nerve, and you lose the ability to move your diaphragm, and so you can't breathe. Okay, so that's one of the reasons why a high cervical injury is so important. I mean, clearly your neck is important for a lot of other reasons. That's one of them. Okay. So looking here, it's exactly what I said. This side. This represents not only exhalation, but also sort of at rest. Like at the end of a normal exhalation, you're at sort of this second by second steady state, right? That's where your diaphragm would be at rest if you stop breathing. Sort of, like I said, concave like that, convex. As it moves down, it flattens slightly, just to increase this section, right? We're talking about this right now. We'll talk about what increases the A&P diameter in just a second. But easy enough, right? Pretty standard. Okay? These numbers are the ones that I'm not super excited about you remembering. Okay? The 760, what are the actual physical pressures? I don't really care that you know those numbers. What I want you to know is the concept behind those numbers, and just let me explain and see if it makes sense, okay? So, the pressure in the thoracic cavity, what am I really talking about? What did I just say between the intrapleural, intrathoracic? I'm talking about the pressure in the pleural cavities. Okay? The pressure in the pleural cavities is normally a negative pressure, -4 millimeters per mercury, as compared to 0, which we would call 760, right? Does that make sense? So at normal atmospheric pressure is 760. Our normal pressure in the pleural cavity between the lungs and the chest wall is normally -4. Does that make sense? Okay? And what does that help do? Keep the lungs adherent to the wall. All right? It helps keep the lungs from collapsing. All right? Inside, the intraalveolar, intrapulmonary pressure at rest is what? 0, 760. It's weird to think that 760 equals 0, but 1 atmosphere. It's equal to the outside atmospheric pressure. Okay? So outside the lungs, between the lungs and the chest cavity, it's negative pressure. Inside the lungs, it's equal to the outside pressure. All right? There's also another pressure called the transpulmonic pressure. Don't worry about it. All right? Don't worry about it. But it should be about 4 at all times. Okay? +4. Don't worry about that. That just also helps push. It's a help pushing out. The negative pressure kind of sucks the lungs up to the exterior, the interior thoracic wall. The transpulmonic pressure helps sort of push them out. So there's multiple forces keeping lungs expanded and not collapsing during exhalation. Does that make sense, everybody? Just again, at a baseline, okay? So, normally, You have a descent of about 1 centimeter, also not critical that I don't care if you know that. And I'm talking about sitting at rest, restful breathing, not moving up and down, not going upstairs, just at rest, sleeping. You don't really move a ton of air because you don't really need a ton of air. Then, if you're exercising, you have the ability for your diaphragm to go way farther down to take a huge breath of air. All right? Simple. At rest, we don't need as much oxygenation because our tissues aren't as active, so our diaphragm doesn't need to descend nearly as far. When we're active, it does need to go farther down to help us breathe in more air. Very simple concept, I think. Does that make sense to everybody? Okay? Diaphragm, 75%. Do you need to know 75%? Is it even 75%? Probably not. Doesn't matter. The majority of the air that goes into our lungs is the responsibility of the movement of the diaphragm. Okay? Easy? Now our other primary inhalation muscle, active expansion, active contraction of the external intercostals. What does that do? Moves the rib cage out. So we're increasing the vertical diameter with our diaphragm. We're increasing our anteroposterior, AP diameter this way, right? Diaphragm will move our lungs down to increase this diameter. Our external intercostals will increase this diameter. What is the overall net? A significant increase in the chest cavity size, okay? As we move down, exhalation, diaphragm moves up like this, external intercostals relax, so this diameter and this diameter both shrink. Air flows out, okay? Fairly simple. And then the external intercostals are not responsible for the majority of breathing. The diaphragm is. Here's that. Diaphragm goes down, external intercostals go out, the whole circle gets bigger. Right? Oops, sorry. The whole circle gets bigger. And air goes in, expiration, exhalation, intercostals relax, diaphragm relax, and the circle gets smaller. Okay? Alright. Pleural pressures, other pressure, again, inside the pleural cavity, it's a negative pressure just to help keep that lung parenchyma expanded and not collapse. We've already talked about that. Okay? But again, you don't need to know that, you don't need to know these numbers. What you need to know is that during exhalation, or during inhalation, the pleural cavity pressure, which is normally negative, goes down even a little bit further, and all that does is help the lung tissue expand with the expansion of the chest cavity. Did you understand that? Everybody make sense? Yeah? So, there's always a negative net pressure even at rest in the pleural space in order to help keep those lungs expanded. As the inhalation occurs, that negative pressure goes down a little bit more just to help ensure that the lungs stay expanded during inhalation so that they don't collapse. Alright? So that lack of the surface tension of the pleural fluid helps keep the lungs open and available for air to flow into them. Again, we're talking about externally. Right? We'll talk about intra-alveolar pressure in just a second, but is that clear to everybody? Okay. And so that's what this bullet means right here. This guy. Adhere tightly because of the subatmospheric pressure, the negative pressure I just referred to, and the surface tension of the fluid, the parietal fluid, pulmonary, pleural fluid. Okay? Now, alveolar pressure. Okay? It's the same, again, we're talking about the actual balloons in the lungs, right? What keeps the alveoli open and prevents them from collapsing on each other? Surfactant, the surfactant that keeps that surface tension low or high? Low, exactly. We don't want them collapsing on each other and then having to hop back open. We want that surface tension to be low. So at normal rest, we have equal pressure in the alveoli and outside as the Diaphragm moves down, the pressure in the alveoli goes down because it's spaced, because they get bigger, right? Just like in that glass bottle, in the alveoli are pulled open and expanded too as the lung tissue expands. And so that pressure goes from equal to the outside to lower than the outside. And what happens? Air goes into the lungs, into the alveoli. Does that make sense? So before we focus on the expansion of the entire lung tissue with the expansion of the thoracic cavity. And now we're expanding, now as that lung tissue expands, those alveoli open up too. And so then that pressure goes down and now air goes in. Okay? I told you, that one picture was going to be 35 slides. Okay? This is one I added for you just for a visualization to help put this stuff together, because I think it's just easier to see this on the diagram. And I will give these to you, but again, you don't have to know these numbers. But this 756 in the gray, that represents the pleural cavity where there is always a negative pressure in order to help keep those lungs expanded. Okay? Inside the lungs, 760 equal to 1 atmosphere, meaning that the intrapulmonary pressure at rest is a net 0, equal to the outside. And again, I told you there is a transpulmonary pressure that is sort of help forcing the lung tissue out. Don't worry about it since I don't have it on the slides, but just understand there is another force that is helping keep the lungs expanded during inhalation and exhalation, okay? But all this is just a visual representation, okay? And I also put this one on here because Boyle's law, sometimes people do better on a graph, okay? Just to explain this for you. This is our atmospheric pressure right here across this line, and this is our alveolar pressure. And as I said, at rest, your alveoli are at homeostasis with their external environment. During inhalation, pressure in the alveoli goes down because the alveoli expand, and what happens? Air goes in. As the space in the alveoli goes down because of the diaphragm moving up and squeezing everything out, air flows out, and we exhale. Okay? So for those of you that this kind of visualization helps, I'm putting it in there. But I mean, again, it is just another way of explaining the same thing that I've said about 40 times now. So I just hope it's clear. Is it clear to everybody? Is anything I've said not made any sense as far as like pressure differences between different places, anything like that? I mean, any questions? No? Are you trying to come up with a question? Just trying to come up with something?
Yeah, it's pretty tough.
All right. Well, if you find one, let me know. It doesn't even have to be related, just a question, just make me feel good.
I'll do it now.
Okay. All right, accessory muscles. Anybody heard of retractions, respiratory retractions, right? So when you have somebody that's having retractions, what that is a sign of is respiratory distress and basically overuse of these accessory muscles. The person is working to breathe, right? If the diaphragm moves normally, the external intercostals move. Even if the external intercostals don't move normally, if you have broken ribs and it hurts to breathe, you can still move most of your air with your diaphragm. You don't really need to involve these muscles unless you're doing forceful inhalation or forceful exhalation. So when you start to observe a patient with the overuse of these muscles, like retractions between their ribs, like intercostal retractions, or clavicular, supraclavicular retractions, you can start to see sternal retractions. You see them using these muscles as a sign that they're in respiratory distress because they are working hard to breathe, okay? So, the accessory muscles, sternocleidomastoid, right? Sternocleidomastoid, right? Helps move this top rib, all right? And the sternum. Scalenes help do the first two ribs. They're sort of from here to here. And I have pictures of them that I needed to add because I think it'd be easier for you. And pectoralis minor, the third and the fifth rib. So if you see the sternocleidomastoid, it helps really kind of pull the sternum and the clavicle up, right? The scalenes, anterior, posterior, they really do this first and second ribs. So they help move that up, all right? And then the pectoralis, 3, 4, and 5th ribs help move those, expand the chest cavity. So just, again, helping increase the AP diameter and the vertical diameter for a deeper, more forceful inhalation to get more air in. Okay? Does that make sense? Okay. So again, when you start to see people using these and you have these sort of sternal retractions or supraclavicular retractions really sucking in, you can see that these patients are working really hard to breathe. And that sort of caveats nicely is like, inhalation is an active process, as I've said, and as you guys understand, because we're actively contracting the diaphragm and the external intercostals. The relaxation of those muscles, not any kind of active force of breathing out. Just the relaxation of those muscles alone should be enough to decrease the, and to use Boyle's law, to move that air out. So passive process. When you start to have to work to breathe, then we need to, clinically, what do you start to think? Obstruction, narrowing, something going on in the lung airways, in the airways of the lungs that's making your patient need to forcefully exhale or forcefully inhale. Okay? Any questions? All right, let's talk about exhalation quickly because we've already done it. It is, again, a passive process. Essentially, what's happening is Boyle's law in reverse, right? The volume of the container is going down, meaning the pressure of the gas inside that container is going up, and so it's going to come out. That's exhalation, all right? Other things that contribute to exhalation, sorry. Other things that contribute to exhalation are the elasticity of the lung tissue itself, the elasticity of the airway, the smooth muscle in the airways, the passageways, contracting sort of a recoil, all right? And the surface tension that does exist. The surfactant doesn't completely eliminate the surface tension inside the alveoli, but it lowers it enough that they don't collapse. But there is still a tendency for them to return back to their normal shape. All right, so that, again, just think of a balloon contracting, the air just falls out of it, right? That's exactly what's happening with the alveoli during normal normal exhalation. We will talk about lung capacities and volumes, but if anybody's ever had a pulmonary function test done, there's a thing called FEV1, forced expiratory volume in 1 second. Most of the air that you expire comes out in that first second. All right? It's not super important for just regular anatomy and physiology, but it does become important when you guys get to pulmonology as far as like lung capacities and volumes and looking at either restrictive or obstructive patterns of breathing. Okay. And do we, look, I'm just gonna ask, you guys got it? You guys got it? Okay. I am really not trying to insult anybody's intelligence, but I found that repetition is useful, all right? So, diaphragm goes up, cavity gets smaller, air comes out. Fair? Right? And it's really this. I don't care if you remember the 762, just know that 762 is higher than 760, and so air comes out. All right? And again, we're inversing Boyle's law. The volume of the container is going down, the pressure is going up, air is coming out. Okay? Forced exhalation, so now again, you can, just as you can take a more deeper, forceful inhalation, take more air into your lungs, you can also blow some out, even at normal resting tidal volume where you're just breathing. Everybody here can just blow extra air out. So in order to do that, there needs to be some muscle use, right? Most of the time, the abdominals, right? You can feel your abdominal strength, that kind of smushes the cavity a little bit to help increase the size, or increase the pressure even further to help get more air out. I added inward because it does, the abdominals themselves, the quadratus lumborum really move the muscles, the ribs down. The abdominals really kind of force them in, so it's kind of a forcing in and downward. So you're really compressing the cavity more. It's a nuanced point, but I just wanted to add that for sort of like, precision's sake, okay? And then the internal intercostals, they also pull, when they contract, they pull things in and down as well. So both of these, you just think are working to compress the AP and the vertical size of the chest cavity for a forceful exhalation, okay? Easy enough? All right, other factors, we've discussed these as well. The surface tension of the alveolar fluid, right? The alveoli do want to constrict back to their normal size, but the surfactant prevents them from constricting all the way down to where they collapse. So that constriction down to their normal size helps force some of the air out. The compliance of the lungs themselves, so if the lung tissue is fibrotic, if the lung tissue is for some reason restricted from scar tissue, whatever reason that they're non-compliant, that will affect our mechanics of breathing, of course. And then airway resistance for something like either an obstructive process or a restrictive process or something both like asthma, right? Where the passageway themselves are affected. That just affects clearly the amount of air that we move in or out, all right? And so we've discussed surface tension. At this point, we know what we're talking about, right? And so for the alveoli, the surfactant layer keeps it from collapsing in on itself, right? It does have still, like if you expand the balloon, whether you have soap in the balloon or not, if you expand the balloon and then you let it go, it's going to have a tendency to return back to its normal shape, right? But what the soap or the surfactant in this case does, is prevent it from collapsing entirely. Does that make sense? All right, so that inward surface tension of those alveoli contributes in a decently significant way to the overall exhalation process. Easy enough? Okay. And so, again, got it. Got what surfactant does. That's what this says. And then here's another picture of surfactant again. The normal surface tension wants us to go inward to return to its normal size, but surfactant prevents it from doing this. Is that clear enough? Because again, what happens then if you have alveolar collapse? That's called atelectasis, and then what does that require to pop those back open? Higher pressure, more positive pressure, right? And so more forceful inhalation. So again, that's what you would see if something like that is happening, somebody working to breathe, because they're having to try to bring that air in to pop those alveoli back open, right? And then every time they exhale, it flows back down, and so that's somebody who's going to be experiencing a lot of that accessory muscle usage, okay? And I was talking about this yesterday, or the day before, excuse me, when we talked about differences in the size of alveoli, right, and what the surfactant helps it do. Because if you have two alveoli within the same alveolar set, which of course you will, they're not all the same size. All the grapes aren't the same size, okay? So like I was saying, it's harder to blow up a smaller balloon than it is a larger balloon. But those pressures have to sort of equalize in order so that one, they both expand, and two, that they don't overexpand. So the surface tension reduction of the surfactant helps contribute to overcoming the law of Laplace, which states that the smaller ones should be harder and need more forceful energy to open. The surfactant helps reduce that and help keep it more equalized so that even alveoli of different sizes expand to their capacity. Does that make sense? That's all I need you to know about law of Laplace, okay? They do have more pressure to overcome, because they are smaller, but the surfactant helps sort of equalize that so that two different size balloons expand at a relatively equal rate within the lung tissue, right? Make sense? Ish? Okay. Clinical correlation for a lack of surfactant. So most often where you run into this is the prematurity. So a baby that's born premature before their lung tissue is mature enough. If they know a baby is going to be born premature because of a specific reason, they can give the patient, the mother, steroids in order to help move along fetal lung maturity. But oftentimes what happens when the baby is born too early is they lack surfactant, they lack the ability to make surfactant, and so what happens to their little alveoli, they stay collapsed, and so they have a difficult time breathing, and so that's one of the major complications with prematurity, okay? And then again, we talked about atelectasis, just for whatever reason, if somebody has a collapse of lung tissue, injury, whatever, the atelectasis causes a greater pressure for them to have to overcome, so they start to have to work to breathe. So again, the role of surfactant helps keep those alveoli open so that patient can breathe through normal pressures. Yeah.
Can you burn off your surfactant?
I don't think so. I don't think so. I mean, because can you lose your ability to create surfactant? I mean, you can if you damage your lung tissue, but like
inhaling superheated air.
Well, that's not necessarily going to burn off your surfactant. If it's going to do anything, it's going to scar the alveoli tissue itself. So the tissues that make the surfactant, those type 2 alveolar tissues are going to be injured. So then, yeah, you lose the ability to make more surfactant just based on a thermal injury to the lung tissue. But it's not necessarily that you just it dries out like sweat on your skin, if that's what you mean. Yeah. Any other questions? All right. Compliance of lung tissue. All right. Again, we want our lungs to be compliant. We don't want pulmonary fibrosis. You guys heard of it? Pulmonary fibrosis. It decreases the compliance of lung tissue, meaning they can't expand, even though there may be sufficient pleural fluid and even though there may be sufficient movement of the diaphragm, the lung parenchyma itself is scarred, so it can't expand. So the pressures can't change the way they should, and so the patient has difficulties with breathing. Okay? High compliance is what we want, low compliance is not what we do want. And then, again, elasticity and surface tension. So again, the easiest way to think about lung compliance is just a fibrotic lung. Does everybody know what I mean when I say a fibrotic lung? Like one that's got a lot of fibrotic tissue in it. Think of scar tissue. How about that? It's not necessarily scar tissue, even though it kind of is. But what it does is instead of being nice and compliant and movement easy, that scar tissue holds things, creates like adhesions and tension so that tissue can't expand nicely the way it should, meaning that those alveoli can't expand the way they should, and so the patient has difficulty with breathing. And it kind of becomes a vicious circle. So areas of lung tissue that become fibrotic, they atelectasize, and so they collapse, and that sort of changes the mechanics of breathing, and that can lead to further atelectasis in other non-fibrotic portions of their lungs. So they have real problems with breathing with pulmonary fibrosis, okay? And then airway resistance, it should make sense to you, even though the airways themselves are just passageways, right? If you have a smaller passageway, what happens? Less stuff can get through it, right? So if you have a restricted, inflamed airway passage, you have less air movement, and you have to work harder to breathe and to overcome that resistance. That's one of the things with asthma. Anybody ever had kids that had bronchiolitis or bronchitis, or in adults? It's just inflammation or infection of those passageways, and so it becomes harder to breathe because you have to overcome an obstacle. It's as simple as that, okay? So high air resistance is bad in general, okay? And asthma. This is one of the reasons why I put on there that there are more parasympathetic receptors than there are sympathetic receptors. Because again, if you have an airway resistance, one sec. Or actually, go ahead, what's up?
So if you had like severe pain, like say you broke a rib or something like that, but it didn't puncture it, would that be considered a compliance issue or more mechanical?
It would really be more of a mechanical issue because it's not lung compliance of that tissue. That tissue is still compliant, right? But you're not going to want to move that area because of pain. So it's really more of a somatic pain response that is the compliance of the lung tissue itself. The problem is that you don't move, the reason we don't tape ribs anymore like they did in Rocky is because it keeps that tissue from expanding and contracting adequately. And so it actually can lead to atelectasis if you splint the ribs and do that kind of stuff that we used to do. So, rib splinting is, if you're playing a contact sport, that's a whole different thing. But I'm talking about, anybody remember used to tape, I'm old. They used to tell us to tape IV bags to people's ribs when they broke their ribs to kind of have a splint. And it turns out that's a really stupid thing to do. So don't do that. So because you can actually cause that bit of tissue, that bit of parenchyma to not move a lot. And then you can incite atelectasis and collapse of that tissue. So, and they can blow it back up, it's fine, they'll live, but just don't do that, all right? Don't go around taping IV bags to people's chests, all right? But does that make sense? Yeah. And so, parasympathetic heavy versus sympathetic heavy means what happens typically if you can't breathe? your fight or flight kicks in, right? The sympathetic response of constricted airways due to airway secretions and things like that isn't enough to overcome the parasympathetic response. So you can't like breathe your way through an asthma attack. Does that make sense? That's really it. You can't, like the parasympathetic stimulation will take over and overwhelm the sympathetic stimulation of the hyperventilation and the bronchodilation. So it's not enough to overcome it. Yeah. And especially with an asthma attack where you really have these inflamed walls, really what you need is steroids, things like that to reduce the inflammation. Okay? But no matter how much sympathetic stimulation kicks in, it's not going to be able to overcome an asthmatic attack. Okay? All right, let's see. I'm going to take us a little bit farther, but I feel like you guys have earned a break, so why don't you take one, and I'll see you in like 10 minutes or so. Okay?
Yeah, is it more the surface tension of the surfactant, or is it just like the actual tissue itself that's keeping it out? So the actual there is surface tension, like it is, you know, when it expands, as it expands, the opens up like a tissue stretch. The surfactant keeps it like open and not all the way down to the actual structure, but it also so it's also just because remember there's a last so the surface tension of the alveolus, also there's other stuff in the alveolus.
Have you ever done epilepsy?
If you drive down the Pensacola, it's still all over space, and they will try to beat it.
It's so easy to take that away.
And also, clear water.
The surfactant in how we all drop inside and over after. Yeah, but it's causing the surface tension. I can't be really bad.
It's not bad.
I would like to go together.
And that's the biggest thing. It keeps it from being stuck together more about yeah, that's like a small part of it.
For phase 2 sites of the blood.
It does because it yeah.
Yeah, we can go there.
And but the main thing
Nobody's put it
Because they probably doesn't have a lot of army presence.
Yeah, but it's still bad. We only have like 10 airports. There's like
trying to differentiate in my head the surface tension of the actual thing is
most of them are
Where you put it?
either Eisenhower or
I got my eye on the old water.
Where's that?
Virginia. It's like 3 minutes.
But I'm gonna go somewhere where I'm gonna stay. Like I don't wanna go to Hawaii. If we go there, they're gonna put me there.
That's medical.
And my family too. Not gonna
It'll probably be open to your first duty station.
I think where do you go for phase 2? You're gonna try to like everybody should be in.
A lot of the phase 2 places being
There's a PD spot here. And it's maps all over it. But you work here, and you don't get one. We don't take any PAs, we take all.
Really what's the
Like, 23, in the slot. It's all like a spine surgery. Right now, if you got here, it's PA.
They're probably gonna say it's all my
Yeah, but
I've been there, done that. It sounds easier. I'll be sleeping on the floor.
maybe just go to PTI, sorry, I got patients.
Why do we train half the time?
Well, that's like at least 2.5 weeks out of every month. And the PA's like, they come out there for like certain days, and the rest of them just be
Maybe for like 6 months.
You do a mass cow, and then you do a. It's got worse than me, just from old to good. Now it's like, you can't push out so much basic here. You can't be out.
I think it's good to like set up to a couple of
The different foods you can get.
I have been
All of it. I would wash your hands.
like,
I got a picture of my son was born in
It's hard in the field. I mean, it's hard in the area.
outside. One thing I just didn't, I couldn't.
If you look around and you see
I was, the first time I was very, it was alright for like the first 2 months, and then I was
soft skills, and then I got there and like that voice, just like teach. So they could find like outcomes and stuff. So I could see how they're doing it, what do you want to do.
so it was like 2 weeks in the house, and then
more often,
fall
like, they don't want to teach. Like, I have to do PAs that would, like, test out that you can carry medication, like, you can test out on it, and then you're allowed to carry it.
I was like, oh, the baby's doing good.
You go to them, you don't.
You didn't have to do much.
There's always down the road.
You can go outside again.
Because they're scared of their life. I enjoy working for doctors. I do injections, suture, like laser, whatever. It just has to be fun.
The whole point is that we can train your medics so they can do it in about 2 years. I'm trying to keep all the stuff flat deck. We used to teach, especially A&P 1 and 2. I would never pull micro out. A&P 1 and 2 is like easy to digest.
We talked about training our medics, and I told them that I wanted to write this. And they said they would fucking teach me, and I was like, my mentality is I want them to continue their education. So I want them to do it like that, so they don't have to do the work, they do the research. That's my want. Like, I'm not going to sure.
It's like, I'm not like,
It's like a lot of build.
But like, you just,
I can understand.
well, I wasn't then. I
Because you have one of them now, like, you don't have the like, I
I
don't
don't
know.
have anybody out there. And I was in reserve. Like, I was
They're
like,
never gonna do training. It's like, first time you go down there, it's like, medics.
I was in reserve. So I wasn't really seeing my needs a lot. So most friends I could make with them, I slept up. It's not that I didn't like it, just that we didn't have a lot of stuff in common. Completely different. Back then I wasn't as social. I was very much a hermit.
I think you're a good
I think I do alright.
I'm not fine. And once you talk, like, I feel like, like, I'm like,
Yeah, I don't like
go say it out loud. Yeah, I saw him like, so you're right, I saw him.
after lunch session. I mean,
No, I know, you don't need this, the bowling thing's on this, right?
Jim drove us.
If I wanted to just be like, you know, if I
Yes.
if I'm
Probably 2 minutes.
No, it's so good.
Okay.
Was that the one with, what's his face from ER?
No, Wiley, I think I know what you're talking about.
He's got like all sorts of.
It's pretty realistic. Yeah, it's not very accurate. He got me on here. It's only one season right now.
Oh, the main. Oh, okay.
The Army doc.
Hold on.
He only comes in like later episodes. I just don't not like another guy.
Oh, yeah.
So the intern, he's like, she's never done that without me.
That's a good way to explain that.
Hey guys.
I'm thinking of it for a while. He was on. That's in my
Yeah, so it's 15 episodes, and then season 2 comes out in January. Yeah, it's on HBO Max.
I was just finishing up the bear.
The Bear?
Yeah,
I'm scarred from that.
Scarred from it?
My S3, he like asked us to say yes chef, and I was like, sure, with all due respect, I've never said yes chef. Now I'm scarred, I'm like, oh. Yeah.
One way or another.
Luigi Kistler is just like, he's like, you guys will respond instead of yes sir, yes chef. And I said, sir, with all due respect, I've never fucking said that to you.
I like to be.
That was good.
Yeah, I think you're.
As some manager.
Alright, what do you say? Okay, so let's go through breathing patterns, and we're gonna do lung capacities, real fast, and then some gas laws, and we'll get out of here, okay? So, UPM, regular breathing, what everybody's doing right now, the breathing we're referring to normal breathing, not breathing extra in or extra out. Costo breathing, what does that looks like it means? It means like you're using your ribs, your accessory muscles in order to breathe. And then diaphragmatic breathing, that's your yoga breathing, right? Namaste, okay? So, modified respiratory breathing, laughing, sighing, and sobbing, of which you see some of all here at ISAP on any given day. Cough reflex, that is stimulated when you get foreign matter into the bronchi, into the airways there. Okay, it is a forceful expiration, exhalation of stuff that's not supposed to be in your lungs, right? Everybody feels that if they ever swallow something and it goes down the wrong pipe, right? Boom, shoots it right out because it's not supposed to be in your lungs. The sneeze reflex is very similar, except it's irritation of the nasal passageways, again more, associated with asthma, pollen, stuff like that. You know, everybody sneezed before, I assume. Okay, familiar with sneezing. And then hiccups, or syngultus, if you are familiar with medical terminology, is just a chronic hiccup. All right. You can have actual chronic hiccups. You'll learn about them in GI, and I can't imagine they are fun to live with. Chronic hiccups. Does anybody know what you give for chronic hiccups? Huh? Glucagon? I don't know. Walk up and scare them. Thorazine, actually. So, I mean, I guess I'd rather be asleep than have hiccups all the time, so why not? Thorazine works. And it was funny that she put, everybody sees the Mythbusters episode where they see how far your sneeze can. 12 feet. So I could like hit people in the back from here if I had to sneeze. I love these high-speed photos of sneezing because it's so gross. Yeah. Those are just garbage slides, I love those. Alright, anyway. So, the act of breathing, inhalation, exhalation, pretty straightforward, right? I told you, very repetitive, does everybody get it? Alright, at least for now. Now spirometry, this is intimidating to folks. Let me just take it down a notch. We are not in pulmonology right now. Okay, we are in anatomy and physiology. We're going to understand lung volumes, but we're not going to have to interpret spirometry, pulmonary function tests, or anything like that, because that's not where you are. So we just want to get a foundational understanding of what lung volumes and capacities are, the difference between volumes and capacities, and that's it, okay? You will have to calculate some lung capacities, but they're very simple calculations. I will show them to you. Deal with it. All right. So, spirometry. So when you have somebody, when you order pulmonary function testing, this is what you're ordering for your patients to go and have these lung volumes and capacities recorded. Okay? Spirogram is the thing, and the values are what the numbers are. All right. This is the start of the record. Okay. When they have spirometry, they have the patient take a deep breath, and they have to take a forceful inhalation, a forceful exhalation, then breathe for a little while until the end of the record. So you read it sort of backwards, all right? On a normal spirogram, you'll have all the values on there. You'll have some interpretations and some interpreted data on there from the pulmonologist who looks at them. But you should be, by the time you leave here, you will be fairly comfortable with reading spirometry and pulmonary function tests, all right? And then even more so as you go into phase 2 and you look at them with real patients up next to them, okay? So, inhalation is an upward deflection, exhalation is a downward deflection, okay? Make sense? So breathe, 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 take a deep breath, that is that initial swing up, take a deep breath, blow all the air out, that's the swing down, and then that regular breathing between the two green lines is what's called tidal volume, your normal inhalation, exhalation volume that you move with a normal breath, okay? So let's just go over all of those. And you don't have to know these normal values either, okay? If I'm gonna have, when I do have you, calculate something, I will give you the value for this, volume is this is the other volume, calculate, use those values to calculate whatever, okay? So I'll give you the values that you need, all right, fair enough? All right. And so tidal volume is the volume of one normal breath. Just sitting here, in, out, that's a tidal volume, all right? Minute volume is that times how many breaths per minute. Easy, okay? So that means your respiratory rate times your tidal volume. So if you take 12 breaths per minute, like most people do, and 500 for average, then you get about 6 liters per minute, all right? So your tidal volume is represented here, between these two green lines. Okay? Tidal volume can be different from one person to the next, depending on the patient's aerobic capacity, their age, gender, height, size. Okay? So it does vary. That's why normal values aren't necessarily super helpful. It is, they have the values that they have on the spirogram. If you look here, you have a value that's in parentheses and one that is out. The one in parentheses is a typical female value, and the ones that are not in parentheses are typical male values. So they are gender norms, gender-based norms based on epidemiology. So your average tidal volume should be about 500 milliliters. So if you send a patient and their tidal volume is lower, higher for some reason, then we'd have to decide, is that pathologic or is it just normal for them? So again, that's one of the reasons why there are normal values given, but I don't need you to memorize them at this point. Fair enough? Okay. So you have respiratory dead space, okay? Does that make sense to everybody, right? You have, what is the upper part? It's the conducting zone. And the lower part is the respiratory zone. But that conducting zone is physical space. So there is air, right? That is anatomic dead space. That's air that you can't utilize. So all of the air that you inspire is not going to make it to the tissues or to the alveoli just because of physical space, honestly, right? So about 70% of your tidal volume, which is your average in and out, inhalation, exhalation, is gonna get to the respiratory zone to participate in tissue respiration, right? But the other 30%, that's gonna be from the terminal bronchioles all the way back to the oronasal pharynx, is going to be about 30% unusable air because it's just air in the tubes. Does that make sense to everybody? Okay. So what we have based on that is what's called the alveolar ventilation rate, alveolar vent rate. So it's about 70% of your tidal volume times your breaths per minute, okay? Does that make sense, how you would get that calculation? Okay. So another way to say that would be 70% of your minute volume, right? Inspiratory reserve volume. Now, everybody sitting here can take a deep breath. You have extra space. You don't take a full inhalation and a full exhalation every single time you breathe, otherwise you're a weirdo. So you have inspiratory reserve volume, the amount of, if you have to blow up, so when you're getting ready to blow up a balloon or blow out birthday cake, that's your inspiratory reserve volume, okay? The amount extra that you can take in. Expiratory reserve volume, again, not necessarily even after forced inhalation, just everybody sitting here has more air that they can blow out, right? So you have some left. What, you like that? Yeah, yeah. You hear that? Anyway, so we have expiratory reserve volume as well, all right? You see, the inspiratory reserve volume is significantly larger than the expiratory reserve volume, okay? So, is our EXV, this little guy right here to here, versus our IRV, which is that big. So you have more air that you can breathe in versus more air that's just sitting there that you can breathe out, okay? What this is, and typically estimated, is residual volume. You see where there is no deflection here? Like the red line doesn't go below this bar. So that can't be measured directly by spirometry. So it is an estimated volume. Because when you blow out your air, there is still some, you don't blow out all of the air that is physically possible to get out. So you do have some air remaining, and that is called your residual volume. Okay? That's why they have these little guys, right? It's an estimated value. Again, based on gender-related norms of epidemiology, right? So, that's this here to here. Right? Easy enough. Okay, so far we've got tidal volume, right? That's your regular air. We've got minute volume, right? Which is tidal volume times breaths per minute. We've got alveolar ventilation rate, which is 70% of that because of the amount anatomic dead space. We've got inspiratory reserve volume, which is the amount over tidal volume that you can take in. Expiratory reserve volume, the amount at baseline that you can breathe out. All right? And then we have residual volume, which cannot be measured directly because it's in the lungs. It cannot be forcefully expired. So there's no way to create a deflection on the machine to measure it. Does that make sense? It literally can't be breathed out, so you have to estimate how much it is, and those estimations are based on epidemiology, which is how we get our 12 to 1100 milliliters. Does that make sense to everybody? Okay. That's volumes, that's dedicated lung volumes, right? So our inspiratory reserve capacity is a volume, or tidal volume is a volume of air that we blow out. When you add volumes together, then you get capacities. Okay, that's why I said your expiratory reserve volume isn't a full breath in and then a full breath out. It's a tidal volume, inhalation, exhalation, and whatever you have left. Does that make sense? Okay? All right. Inspiratory capacity, now that becomes not just how much can we take in on a tidal volume, but how much can we bring in on top of it. That's a full inspiratory capacity. Does that make sense? Okay? Functional residual capacity is our ERV plus our residual volume, so half of that is estimated, right? You'll see inspiratory capacity being a lot. FRC is not super useful, this one is useful, okay? But if you look at the capacities here, you have tidal volume plus inspiratory reserve volume. So how much capacity do you have for inhalation? How much air can you take into your lungs? That's your inspiratory capacity. Does that make sense? Okay. Vital capacity. And these are good that they're on the same slide because vital capacity is different from total lung capacity, right? And why? Because of residual volume. Okay? Residual volume is air remaining in the system. Vital capacity is how much air you can take in, how much air you can breathe out, and how much air you take in a normal breath. So tidal volume plus IRV plus ERV. How much air can you move in and out? Does that make sense? That's vital capacity. And then on top of that, there's that residual volume that you can't read out, and that's why total lung capacity is higher than vital capacity. Is that clear? Okay. So again, vital capacity is how much that you can physically move in and out, but then there's that little bit extra for total lung capacity. Okay? And again, we don't have to interpret modifications of these volumes or capacity. We just need to be able to understand what they mean at baseline, at face value, and then how to calculate the capacity. Okay? Yes, sir.
Is this like inspiratory capacity as a result of like you increasing the pressure in that respiratory zone? It's like how you get so much more air
Yeah,
in the lungs?
exactly. It's you're using your expiratory muscles. You're forcefully contracting your abdominals and your internal intercostals, right? You're forcing the air out, right?
And is there no
The same way as forcing the air in. Like I can make the diaphragm go down lower. I can make my external intercostals expand. But now I'm also using my scalenes, my pectoralis minor. I'm using my sternocleidomastoid to move as much air as possible.
Is there any element of like your normal tidal volume is not actually moving air into all your respiratory zones?
Yes, 100. Well, the air is going into the respiratory zone, but at any given time, if you're at rest, if you're sleeping, you are probably only filling up 75% of your lung tissue at capacity. The rest of it is just residual volume air that's keeping those alveoli open, but you're really not moving. Air might get to it, but you might get to like some of the farther distal microscopic alveoli that are not necessarily being utilized. All right, is that what you're asking?
Yeah.
There's other capacities too that are far more clinically applicable, which is why we don't talk about them here. Like I said, that forced vital capacity in 1 second, FEV1, forced expiratory volume 1 second, excuse me. So that's, again, that you have your patient blow out in 1 second. And depending on if that FEV1 versus your forced vital capacity, the ratio is increased or decreased, you can diagnose the patient as having an obstructive disease or restrictive disease. So there's a lot of different ways you can interpret PFTs, but we don't need to go there. So I just need you to understand this guy right here. But, Captain Griffin, does that answer your question?
Yes.
Okay, anybody else? All right, excuse me. So alveolar air, guys, you probably have seen this before. It's not mostly oxygen, right? It's mostly nitrogen. Excuse me.
Tough reflex.
So, again, composition of alveolar air is mostly nitrogen. The reason why we don't have more nitrogen in our bloodstream is because it's not very soluble in blood, thankfully, right? So we'll talk about solubility of gases here in just a little bit, but alveolar air, okay? Really what this says is that, the lung tissue, as it moves through it, it's warm, and then as it moves into the alveoli, the alveolar air composition begins to change immediately because of the diffusion, because of the air moving, oxygen moving out, carbon dioxide moving in, which is why, you breathe 1 second to the next, right? You breathe in, you have a ton of oxygen in the alveoli. As you breathe out, which is a half a second, that's changed in composition to a significantly higher portion of carbon dioxide, right? Does that make sense? That's how fast it happens. And we'll talk about what facilitates that quick exchange here in just a minute, but we have actually already talked about one of them. What, does anybody remember? The very thin like the fusion of the basement membrane. It's a very small diffusion distance, exactly, right? Good. Any questions so far? All right, gas laws. Simple, simple. Keep it simple. Trust me. All right. We talk about partial pressures. When you guys start to measure arterial and venous blood gases, you'll measure the partial pressures of each gas in the blood as it exerts, what pressure it exerts. Okay. So in a mixture of gases that don't react together, meaning just imagine atmospheric air. Okay, each gas is doing its own thing. When it gets into the alveoli, they each exert their own partial pressure independent of one another. Okay, that's essentially what that's saying. So the sum total of all the partial pressures of the gas in the system is equal to the individual partial pressures, meaning they're not interacting with one another, all exerting a pressure on the system as if they were there by themselves. Okay? What does that mean? It means that if you have more of one gas in the system than another, it's not going to, it's not going to allow another gas to overcompensate or take part of its partial pressure. Each one is going to exert its own pressure as if it was an individual by itself in the system. All right. Why is that important? Why is partial pressure of any given gas important in the system? What do you do? Diffusion. Exactly. Partial pressure directs diffusion, simple diffusion, right? The partial pressure of the oxygen that we breathe in, is it higher or lower than the partial pressure of the oxygen in serum? It's higher. We have more oxygen in the air we breathe in than we do in the tissue level in serum, right? What is the partial pressure of carbon dioxide in the air that we breathe in compared to the air that is compared to the partial pressure of the carbon dioxide in the system? It's lower, right? We have more carbon dioxide because cellular respiration has been occurring. We've exchanged oxygen for carbon dioxide. Carbon dioxide comes out that way when we breathe out. It's mostly, well, it's not mostly, but it's a lot of carbon dioxide, a lot more than we breathe in at least. That's Dalton's law. That's the importance of Dalton's law. That's where I want you to be. Does that make sense? I know you look at these past two slides like, what the? Does that make sense? Partial pressure and the facilitation of simple diffusion. That's why it happens. Okay? So again, this is the bottom line, not up front, the bottom line buried at the bottom. But it is the bottom line, okay? So the gradient helps us move. And we can affect partial pressures of oxygen, of carbon dioxide, if we change atmospheric pressure. Right? We'll talk about briefly hyperbaric medicine and things like that, how that affects pressures, partial pressures, right? Like, you guys have heard of the bends, right? At depth, nitrogen becomes more soluble, so nitrogen bubbles get in the system as you ascend too fast. And so then you need to put that pressure back at pressure to get them out. That's hyperbaric medicine, right? Part of it. Anyway, Henry's law. Henry's law can be explained with a bottle of Topo Chico. Has anybody here had Topo Chico before? Or any soda at all? All right? Topo Chico notorious for being extremely carbonated. If you open it too fast, it's going to get you. All right? If you've never had Topo Chico, open it slow. Anyway, Henry's law is how much gas that will dissolve is proportional to the pressure above the gas, right? So, you have a bottle of soda, it's hard. When you first get it, it's firm, right? Because there's still pressure, there's still carbon dioxide from the liquid to the top of the bottle, right? Pressure is high. Open the top, what happens? Bubbles. Why? Because the pressure is lower now, and so the pressure that has been keeping that carbon dioxide in solution goes away, so the bubbles form and the carbon dioxide comes out of solution in the form of bubbles. That is a practical application of Henry's law. Can everybody sort of visualize that? That's really what it is. Why is that important? Because if we need to change partial pressure, if we need to dissolve more oxygen into a patient's system for whatever reason, we can put them into a high pressure system and force more oxygen into their bloodstream. Does that make sense? So there's a clinical application to it. It's not just gee whiz. But does Henry's law make sense? Both. Okay? All right? So again, that's enough. We got it, right? This one here, like I said, mostly we're breathing in nitrogen, but not really very soluble, so at normal atmospheric pressure, it doesn't come into solution very easily. All right? That can be changed with differences in pressure, if we're thinking about nitrogen. But again, the easier ones, carbon dioxide and so on. Right? Hyperbaric medicine, that was what I basically just went through, right? Put somebody in a high pressurized oxygen situation, more oxygen dissolves into their system, and so that can help treat things like burns or chronic wounds, where we don't get a lot of blood flow, and meaning if we don't have a lot of blood flow, we don't have a lot of oxygenation. So you have somebody with chronic wounds, you can put them in a hyperbaric chamber. Somebody with carbon monoxide poisoning, you can put them in a hyperbaric chamber and force the oxygen onto the hemoglobin, right? Various other things. Dive medicine, you guys know about, I'm sure. Does that make sense? That's what this gas gangrene and the skin grafts, right? Skin grafts, it can improve skin grafts because typically, your body wants to reject tissue that doesn't belong there. You increase oxygenation of the tissue, and a hyperbaric chamber can help with an uptake of those skin grafts. So a lot of reasons to use Henry's law and Dalton's law to a certain extent as well. Okay, we're almost done. You can see it. You guys are all right. Any questions? Gas laws. Slides look intimidating, but I don't want them to be. Does it make sense where I want you to be? Yeah? Or maybe the slides don't look intimidating. Maybe I'm just dumb and I think they look scary. But, all right. I just don't want, you start to see gas laws and like your eyes roll back in your head and you're like, oh my God, I'm in earth science again. I don't want to be there. So, external respiration. What's that? Gas exchange at the alveoli level. Yeah, at the level of the alveoli, basically. We're taking the air from the atmosphere, we're putting it in the alveoli, and then we're putting it into the blood. Okay? Ventilation moves the air to the alveoli. Respiration takes place in the respiratory zone, where we have actual exchange of gas. Okay? These are also things, if you're looking at numbers, I don't care about you knowing those exact numbers. What I want you to know is the concept behind the numbers. And we have just literally done the concept behind the numbers. The air you breathe in has a higher pressure of oxygen than the blood, and so oxygen is going to move from the alveoli into the blood, right? And vice versa, okay? Does that make sense? Okay, because that's what this says. Then you have systemic gas exchange. Do you think it changes at all? It's the same concept. Okay? The partial pressure of oxygen dissolved in your blood, in your arterial blood, is higher than the partial pressure of oxygen that is at your tissue level. So oxygen is going to come off and deliver itself into the tissues, and CO2 is going to come on and be delivered back to the lungs for exhalation. Okay? That is these two slides. And I don't want to shortchange you, but does that make sense? That's really what it says. I don't want you guys, you don't need to know the numbers, but the concept makes sense. This is high, this is low, right? So which way is oxygen going to go? It's going to go from here to here. Is that, I mean, that's an oversimplification, but that's it. Does that make sense? Okay. Here's a picture. Okay. Maybe the big arrows might help. So, we're really almost done. You guys have done a wonderful job today. I appreciate it. Surface area. Have we already discussed this? Yes. What did it say? Millions of alveoli. What do those millions and millions of alveoli do? Create a tremendous amount of surface area. If you were to take that alveolar sac and get rid of all the septa and just make that sac, instead of individual alveoli, into just a one big balloon, what have you done to the surface area? You have taken it exponentially down. Just like I talked about in the GI tract. Like I said, I think these are really good analogies. If you eat wheat and you have a gluten allergy, it takes all those microvilli and it flattens it out. And so all you have is just a straight tube, rather than that miles and miles or hundreds of square meters of surface area, right? Same thing here. So when you start to lose your alveoli because of chronic obstructive pulmonary disease, because of smoking, because of whatever, you lose that surface area, you lose oxygen diffusion, distance, and capacity. And so then that patient has a harder time breathing, and typically they'll have a lower amount of oxygen running around in the system. Does that make sense? All right. And then, as you said already, and as we have talked about, diffusion is greatly decreased in the alveoli in a non-pathologic state, so that that air doesn't have a long distance to move. Now, if you add interstitial fluid, if you add alveolar fluid in the actual lungs, what happens to that diffusion distance? It increases. That stuff has to move farther, so you lose efficiency of respiration, and so that patient doesn't oxygenate nearly as well. So does that make sense? Honestly, just think about how far the air has to move, okay? And that, as they say in the business, is that for today. Tomorrow we have about 30 slides. We'll talk about the oxygen dissociation curve, not in a biochemical way, but really just in a clinical setting, like in the, if you're acidotic, if you're at altitude, what is the tendency of oxygen to dissociate from that hemoglobin and actually be delivered to the tissue? Has a lot of clinical applications, but we're going to take it at a very surface and foundational level. So unless you have any questions,